So, for the next 40 or so minutes, we'll talk about the team approach to COPD disease management. And again, I'm Lana Valera. Just a quick course overview of what we're talking about. Obviously, the multidisciplinary care approach has been reiterated several times in the multiple talks from earlier this morning on how important it is. It's also as important as the patient's desire to improve their health and wellness. The World Health Organization, this is a quote for them, that an effective COPD management plan includes 4 components: assess and monitor disease, reduce the risk factors, manage stable COPD, and manage exacerbation. So when you think of the third piece, manage stable COPD, that's where we come into play. We as healthcare givers, how do we manage that effectively? And not just individually, but as a team. With COPD being a multi-system disease, the role of the RT, the pharmacist, the registered nurse, case manager is as important as the role of the physician. Again, looking at that team approach. And that's pretty much the resonance of what you're going to hear in this presentation, reminding us that a team approach to COPD management is what would help that patient. And in this presentation, we'll review the roles of all those different caregivers. And we'll emphasize the importance of making sure that it's patient-centered care and not just individual roles. So for CEUs, we have to identify the objectives, and so the 3 objectives for this presentation is we'll describe the importance of patient-centered multidisciplinary care approach to COPD. At the end of this, I also hope that you'll be able to identify the different roles for the patient, the physician, the RT, the case manager, the nurse, the pharmacist, the dietitian, the occupational therapist in COPD disease management. And we'll also review a few literature that shows us what's out there and what folks are doing from a team approach for COPD management. Did I go the wrong way? Okay. So patient-centered COPD overview. Current research shows that COPD is a fast-growing disease with lasting effects on healthcare. Obviously, that's why we're looking at it today versus several years back. Again, COPD has always been a disease of great importance, but now that it's going on the list of readmission issues, the financial side is becoming more important as well to hospitals. Here's another quote from the World Health Organization, basically helping identify COPD as a chronic disease. It says, chronic diseases such as heart disease, stroke, cancer, chronic respiratory diseases, and diabetes are by far the leading cause of mortality in the world, representing 63% of all death. So you've got other factors like trauma, you have other factors like infectious diseases that cover the rest of the 37%. But when you think of all these things combined making 63% and respiratory diseases play a key role, COPD is that big chunk. And so to see that coming up now, it's really important for us as caregivers to start focusing on COPD, more so in our conversations as we talk about CHF, the same way we talk about diabetes. COPD is a comorbid disease and with multi-system impacts similar to sepsis. Now, knowledge that sepsis is more of an inpatient situation where there's infection and you're taking care of those patients right there and then, you have to look at it chronic. If you look down here, chronic part of the definition of COPD implies a disease with long duration and slow progression. So that's the only other thing that differs COPD from sepsis being a multi-system approach. So it's not something where the patient comes into the hospital when you have COPD and automatically, or you can do A, B, C, D and cure that patient. This is something that you have to follow that patient for X amount of months, years, and up until their lasting days. It affects primarily the respiratory tract, including the lungs and upper airways, the GI tract, as we've talked about the diet and all other aspects, and eventually the cardiac system. Patrick Dunn talked about how the right heart has to work to compensate to get that blood, oxygenated blood to the rest of the body, to the lungs, and then to the rest of the body through pulmonary hypertension. So at that point, COPD starts to affect your cardiac effects as well. All right, so looking at patient-centered multidisciplinary care, obviously just reiterating that treating COPD requires a multidisciplinary approach. Since the disease itself involves several organs of this body, since we know that disease cannot be cured, and since we know that the comorbid effect of patient care plays a big chunk of that patient, it is important to look at COPD from a multidisciplinary approach. COPD disease management should mirror similar comorbid diseases such as diabetes or CHF. So the same way we have diabetic coaches, the same way we have diabetic educators, it's important to start to think of COPD in that approach, having someone who's a champion, and that's where the role of the respiratory therapist comes in. But again, we'll look at different literatures that shows you different hospitals and different facilities on how they put that sole championship on either the RT or the nurse or someone else. But at the end of the day, if we go back to thinking of it as a group approach, then it's all about that patient. So the care of the patients by a multidisciplinary team is usually organized under the leadership of the physician. Each member has specific responsibilities, and the whole team contributes to care of the patient. So I wanted to point out some of the benefits of a multidisciplinary care approach. And most of us know these from being in the ICRs, joining in different multidisciplinary approach. Improving patient outcomes. When you have different minds thinking together, two heads are better than one kind of approach. What the doctor may think of, the RT may, the dietitian may, someone else may bring this to life. It also improves the process outcomes. When you do things over and over again, through the process you get better at it, and then you become more efficient for that patient's care. Increasing the patient's satisfaction. When you have a handful of people, 5 to 6 professionals working on a particular patient, and not just in a one-time situation, over a long period of time, that patient feels good. They feel like, okay, I have these people that are truly helping me, and they become satisfied. A satisfied patient is more than likely a healthier patient, more than likely someone who will do what they need to do to better their care. Patrick talked a little bit about blaming on the patient, but as much as we share our interest for that patient and let them know that we're there, then that patient does not feel the blame factor. They don't necessarily feel the fingers pointed at them if we're there with them through the process. Another benefit of multidisciplinary approach is it increases staff satisfaction. An RT always wants to feel like the doctor believes that they know what they're doing. A nurse wants to feel like the doctor believes that they know what they're doing. And so when the physician identifies the different roles of each one of these caregivers and appreciates it, then there's staff satisfaction as well. It reduces malpractice claims and obviously reducing clinical errors. I thought this was important, this quote here from Andrew Carnegie. Teamwork is the ability to work together toward a common vision, in this case, the patient's well-being. The ability to direct individual accomplishments towards organization objectives. It is the fuel that allows common people to attain uncommon results. Alright, so just looking at some of the key factors affecting multidisciplinary approach as well. Role clarity. It's important that as much as we work together as a group, we still have some clarity on who's doing what and where the buck stops. Who's responsible for which aspects of care is important, who discusses which issues with the patient. Having knowledge of your own responsibility as well as that of others would also play a key part in working together as a team. Embracing diversity is another big part. Team members must value expertise and contributions that various healthcare professionals bring to patient care. So the doctor can't just feel like, oh, okay, I'm a doctor, I'm going to make all the orders and I'm going to direct to the care of this patient. That wouldn't really bring the benefit out of a multidisciplinary approach. It's also important to know that recognition of coworkers when things are working right would help in moving that team approach in the right way. So example, if the pharmacist pointed out something that the RT didn't point out to the patient, I think it's important for the RT to say, oh, pharmacist, thank you for doing that, I missed that part of it. So recognizing each other is important, as well as measuring the outcomes so we can move on to better processes for that patient's care or for other patients in the future. soliciting feedback from the patient, because at the end of the day, since it's a patient-centered care, that patient gets to see every one of the team members at different points. So getting their perspective on what's going on. Sometimes the RT may spend this amount of time with them and not really go in depth on what's needed. And then case manager may do the other, the opposite. The patient will be the person that can truly tell you what's going on. Alright, so we're going to go over some of the members of the COPD management team. Now, when we go to the literature review, you'll find that there are different organizations that do it differently. But this is a common trend of what I've seen for COPD management team. Obviously, the patient is important, having a physician, a respiratory therapist, since this is a COPD respiratory disease, a case manager, a registered nurse, particularly when it comes to inpatient care, pharmacist, dietitian, and occupational therapist. So I color-coded the first 5 as the primary care team, as those that would most likely spend most of the time with the patient. But that didn't take away from the other 3. Sometimes a patient that has a diabetic patient will probably need more of the registered nurse than they'll need the RN. More of the registered dietitian that they'll need the RN in their outpatient care. But of course, if the patient is in the hospital at the time, the RN plays a bigger role. So this is just kind of like a template, but across the board, when it comes to being about that patient, whoever needs to be there at that time is who we focus on. Alright, so let's look at the patient. When we think of an ideal patient, yes, there's this blame game on the patient not necessarily. Most of the patients that have comorbid diseases don't take care of themselves. They don't have the initiative. They don't feel motivated. But, there is an amount of truth to that. A patient that would seek help is a patient that would succeed in managing their COPD. And also for them to seek help, some patients have to be self-motivated. Those patients that are self-motivated, that want to feel better, that want to go golf with their grandson, or want to go fishing with their granddaughter, or whatever the case may be, would more than likely be a successful patient. So those that seek help, those that are self-motivated, are the kind of patients that would really succeed through a pulmonary rehab program, or in essence managing their disease over the course of their life. A patient that also follows instructions. A COPD patient that would excel in managing the disease will follow the instructions of the caregivers surrounding them. And yes, it goes back to pointing the finger at the patient, but a patient that would follow instructions will more than likely succeed over that wouldn't follow instructions. We talked about it in the last presentation from Ultimate, how the nurses may give them all this information and tell them this is what you're supposed to do and what you're not supposed to do. And if they go home and they don't do that, the chances are they're going to come right back in the hospital in 30 days. So a patient that will follow the instructions given, are more than likely going to be okay. Also, patients that will do their own independent research. For the most part, our demographic may not necessarily be, in this particular environment, may not necessarily be the kind of people that will do independent research based on socioeconomic status, but patients that would actually take that step to find out what's out there, what do they need to do on their own. Is there a support group somewhere? Is there a COPD foundation in their neighborhood that they could go spend some time with other people? Is there a Better Breathers Club? Those are the kind of patients that would truly succeed through a disease management program. And as long as they bring those information back to their caregivers and they're not just making decisions on their own right off the bat, they should be okay. Alright, so the role of a physician, and most likely will be a pulmonologist in a particular case, Patrick talked about the different stages, the 1, 2s, and 3, and the 4, and those that are obviously more severe situations, more than likely will be taken care of by a pulmonologist. The role of the physician is diagnosis, primarily. When you diagnose the patient, that's what the physician does. And diagnosis, obviously, as he mentioned, has to be through the spirometry testing. And so that kind of, and we'll go through these roles, you find that some of the things, cross boundaries. The RT would help through the diagnosis by the test. The physician is responsible for a thorough assessment of the patient, including the history of the disease, smoking history, degree of dyspnea, hospitalization, coping skills, current activities of daily living, depression, nutritional status, vaccinations, and so on and so forth. So when the patient visits the physician for the first time, the physician should be able to do a full assessment of that patient and identify what things need to be focused on. For example, there may be a patient that's more concerned with their diet, and so they need more of a dietitian. There may be a patient, they may have patients that just the knowledge of COPD affects their emotional status. They become depressed. You're going to need possibly a psychiatrist or psychologist to spend some time with that patient. So once the physician identifies those things, the action plan can be drawn out. So the goals and the action plans, again, are the responsibilities of the physician, but in partnership with the respiratory therapist. Since the respiratory therapist would be, one way or another, the project manager, the primary project manager for this patient's care, it's important to have them active in the planning process of that patient. And then the last responsibility that I have outlined here is education. A frequent assessment of the patient's condition would allow for the modification of the action plan if that's needed. So a constant reassessment, the patient may have to come back and see the doctor once a month. For the initial stages, it may change to once a quarter, but an evaluation of where the program is going, where the pulmonary rehab program or where the disease management program is going, is important for that patient's care. Just a side note, the pulmonary rehab program is one part of that patient's care. That patient is not just restricted to the pulmonary rehab program, which is a 12-week program in our case at this facility. Once they're out of that program, they have to continue to manage their disease. And so thinking of it in that big picture, they have to follow up evaluations with the physician. So the RT's role is obviously respiratory assessment. Doing an initial assessment of the COPD patient and identifying where they stand. Patient education is a big part of the RT's role as well. Educating them on things as simple as how to take their medications, how to even test themselves, identifying what their symptoms are, what to do through the action process, through the action plan. You're in step B now. What do you need to do to take yourself back to A? How do you get better from this situation? If you have an exacerbation situation, what do you do right then and there? How many puffs of albuterol do you take? So full education of what to do in self-management comes from the respiratory therapist. And then documentation is another important part. The RT's role, being the primary project manager, is documenting what's going on. In a pulmonary rehab program, they have a chart that the pulmonary rehab specialist will document the activities through their sessions. But beyond that point, a patient that has that goes to a physician that has an RT that helps with this plan could continue to document through the patient's progress. That's what the physician would assess and see where the RT is where the patient's wellness is improving or not. And we'll have all these slides on the website as well when we're done, so that's why I'm not really reading verbatim. The last role I have here for the RT is tests. Obviously, Patrick touched on that extensively, talking about the spirometry testing, which helps identify FEV1, and FVC ratios, which is what is looked for by the pulmonary function test. It's interesting, I was sitting there when he was talking, and he was talking about peak inspiratory flow. The peak expiratory flow is something that's typically used for asthma patient in outpatient settings, or in the ER. The patient comes in the ER, and obviously you don't have a bedside spirometer right there to assess where they stand. You do a peak expiratory flow for an asthma patient. But for a COPD patient, more than likely you want to see whether or not they can inhale. So that helps you identify whether or not they can take their MDIs just about the right way. Do you need to give them a breath-actuated nebulizer, or do you need to give them a mask treatment at that point? So peak inspiratory flow is the role of an RT as well. Peak inspiratory flow, yes. So we had the ultimate folks come talk a little bit, and it's interesting. The case manager role is similar to what they were talking about primarily. being a health coach, being that support, social worker of some sort. And of course, there are different roles when you define it. But in essence, this is just a title for someone who would help that patient through identifying support groups, help that patient identifying other parts of their comorbid situations and how to tie those lines together. Do they need to sign up for a diabetic education course? That's the role of the case manager, coordination of the program for that particular patient. The case manager will also help with resource allocation. Fortunately, with the Affordable Care Act, everyone at this point should be insured, and so finding resources should not be that big a deal. But when you have patients that are not as literate on where to go to even go find that information, knowing that they can call their case manager, and the case manager could direct them to where they need, or at least find that information and share with them, that is helpful to the patient. So that's where the case manager comes in. The case manager helps them identify those resources locally that the patient themselves may not be able to find for their support mechanism. So they also function as a support team member. So the registered nurse, as I mentioned, their role really comes in for inpatient settings. So you're on the floor and you have a patient that's diagnosed with COPD. As an RN, knowing that knowing what the distress level is for that patient is important. Knowing that maybe they are on 2 liters of oxygen at home PRN is important. Knowing that, okay, at that point I could put them on a couple liters of oxygen. Knowing when to call the RT or the physician to the bedside is important. So that's where the role of the RN comes in. Truly in the inpatient setting, identifying those things, those points, those critical points that the respiratory therapist or the physician needs to be at the bedside. The levels of severity, as Patrick talked about, is important as well. Knowing where the patient stands on that spectrum truly helps. So the role of the pharmacist as a secondary team, I've tagged them here as most important for a secondary team membership. And that's partly because the pharmacists, in this day and age have become an educator of some sort. When a patient goes to the pharmacy, they get their medications and the pharmacist tells them how to take it, when to take it, all those kind of information. And so the role of the pharmacist really comes closer to an educator. As I mentioned, they assist the patient identify what combination of drugs work. They counsel the patient on the appropriate doses for rescue situations as well when they have exacerbations. They also help patients identify when to activate the next medical level of their action plan. So if the physician has an action plan specific for that patient, the pharmacist will help them identify the medical part of it. Okay, now my respiratory rate has gone up. These little things, these quick indicators. What do I do medication-wise? Do I take prednisone right away, or what do I do at this point? The pharmacist will help with those educations. All right, the registered dietitian. The role of the registered dietitian is to assist the patient who are finding it difficult to. Oh.
Just touch the screen or touch the pad.
Uh-oh.
Uh-oh.
That means that I can go home.
Went to bed.
There it is.
There we go. Okay. All right, that was scary. So the dietitian assists the patient with their nutritional needs in order to avoid malnutrition, weight loss, and diminished energy levels. What's interesting with COPD patients are, if you've been in the ER, you see some of them like real frail, real skinny, 120, 130 pounds, people that are, well over 6 foot sometimes, and they're just sitting there. They're not nourished. They have malnutrition issues, and so having a dietitian help them through that, and also helping them identify, something as simple as what quick meals they could cook, nutritional wise. How can I provide myself with the daily nutrition that I need? The RD could help the patient identify that, and help. And at the end of the day, the goal is to help with the patient's energy level. If their energy level is not where it needs to be, their activities of daily livings are affected. They're not motivated to do what they need to do to stay active for their pulmonary status. So the dietitian plays a key role as well as a team member for the patient. Patrick talked a little bit about the occupational therapist as well. The occupational therapist's role is to assist with the activities of daily living as well, and to ensure that those activities are not interrupted by the patient's illness. So when the patient has COPD and it's a disease that they have to live with, they have to manage on a daily basis, simple tasks become difficult. What you and I take for granted become real difficult. Picture a 65-year-old grandma that her grandson lives downstairs, and she's got to go watch him for a couple hours between when daddy comes back and mommy goes to night shift. This is a lady that has to climb the stairs at least on a daily basis twice. That's a lot of work. And so having the occupational therapist help them, even basic thing as simple as structure yourself, timing, knowing that, okay, it's going to take me 10 minutes to walk down 20 flights, whatever the case may be. Having that consultation with an OT, Debbie over there mounted 25. Yeah, some people it takes them an hour. And so having the occupational therapist help them through that is important. We can't take those little things for granted. The OT's expertise is needed for patients with severe COPD symptoms. I believe that a periodic session with an occupational therapist could teach the patient how to live the best life possible. All right, so we're going to look at 3 different articles just to cover. I think we're good on time. We're going to look at 3 different articles just to show us what's out there for a multidisciplinary care approach. It will help us see the current practices. And again, I mentioned earlier, some organizations have different caregivers carrying different roles, so don't be alarmed by what we may see. So the first article is titled Multidisciplinary Care of the Patient with COPD. Those are the authors. I'm not going to read them all. But their affiliation include, I thought I'd bring this up. These are important facilities: Temple University, the Cleveland Clinic in Cleveland, Ohio, Columbia University. And I got this article from the American Thoracic Society. So the National Emphysema Treatment Trial, it's called the NET trial, used a multidisciplinary team approach to implement the maximum medical care protocol, including adjustment of medications and outpatient pulmonary rehab for all patients and nutritional and psychological counseling as needed. This article discusses the benefits of such an approach and the care of the patient with COPD. Team member roles complement each other and contribute to the goal of providing the highest quality medical care. The primary focus of the team is to reinforce the medical plan and to provide patient education and support. So basically this article just looks at the multidisciplinary approach. It identifies the benefits of a multidisciplinary approach. It identifies the team roles as complementing each other, working together, again, team focus, and contributes to the goal of providing the highest quality care. In this particular article, the team members identified were nurses, exercise specialists, social workers, dietitians, and physicians. Notice there was an RT is missing. I know, interesting. So the development of the action plan of care in this article is broken into the patient assessment, goals, and plan of action and evaluation. So that's how this article believes that the patient's disease management should occur. They believe that there should be an assessment, an action plan, and evaluation, which is plan, implement, evaluate, PI. The patient assessment responsibility is outlined for the physician according to this article. The patient assessment included respiratory assessment, history of conditions, degree of dyspnea, smoking history, coping, pretty much the things that we talked about at the beginning of this presentation, nutritional status, a full assessment of where that patient stands. That's what this article believes the role of the physician is. Now, if you look at the respiratory assessment, more than likely a respiratory therapist could help with that. The goals and the action plan in this presentation focused on individualization for each patient, maximum medical therapy, and patient education. So this program believed on a tailored program for the patient, not a blanket therapy. Now, when we think of pulmonary rehab program, it's not a blanket therapy, but it allows for a support group. It's a kickstarter. It gets that patient initiated. So this program focuses more than just the pulmonary rehab, and believes that the pulmonary rehab program is actually part of what should be the big picture for that patient. Maximum medical therapy, just talked about bronchodilator therapy and steroids, and then patient education. Of course, that's the part that we believe that the RT could help with, the pharmacist could help with, the nurse could help with. The patient education section focused on symptoms of COPD exacerbation, medication schedule and use of device, smoking cessation, lung volume reduction surgery, and nutritional strategies. Obviously, nutritional strategies come into play with the dietitian. The evaluation section focused on assessing whether the plan is continued or revised based on evaluation of outcomes. So that's seeing whether or not they need to reevaluate the outcomes for that patient. So that's what this article kind of focused on. In conclusion, the multidisciplinary model described in this article defines the essential elements of a comprehensive plan. Although the team in this article does not include the respiratory therapist, pharmacist, or OT, I believe that we could deduce the role of each one of these key players as that of the exercise specialist. If I didn't want to go too much in depth on that article, but when you break it down, what this article was saying the exercise therapist should do kind of falls into that RT, pharmacist, and OT section. The team's focus is on providing education and reinforcing the medical plan. So that's one article. Here's the second one. A multidisciplinary approach to the treatment and management of COPD. Quite similar to the first one. Those are the authors and the affiliation. This is an article from Canada, British Columbia, to be exact. And it was found in the British Columbia Medical Journal. Alright, so I'm not going to read all of that like I did earlier, but I'll just touch on a few key things. Pulmonary rehab, obviously, education, self-management, and nutritional advice have all been shown to improve the quality of life and to reduce the exacerbation of hospitalization in patients with COPD. So 1, 2, 3, 4 are the key factors, according to this article, that would prevent that patient from coming back into the hospital. Pulmonary rehab is something that we have here in this hospital. Obviously, the education component goes into pulmonary rehab. Self-management kind of ties in, and then that's where the ultimate people come in. And nutritional advice could come in as needed for particular patients. That's also touched on a little bit in the pulmonary rehab program. So the content of this article focuses on smoking cessation, pulmonary rehab, as mentioned, education, self-management, counseling on nutrition, bronchodilator therapy, and end-of-life factors needed for an effective disease management program. Sometimes the COPD patients don't get diagnosed until the latter part of their disease. So, you know, it's unfortunate. It's a disease that can be cured, so there are some conversations on end of life that needs to start to take place. This article calls on the role of the physician as the head of the multidisciplinary team, and scarcely states other healthcare providers in particular, but identifies the need for other caregivers to assist the physicians through the process. So this particular article was written by the doctor, and that's pretty much all it looked at, a physician approach, but identifies that there are other care team players that could help. Alright, so we could deduce from this, from the sections outlined, that the RT will be responsible for smoking cessation, pulmonary rehab, bronchodilator therapy, sections of the patient. The dietitian will be responsible for nutritional counseling. The education section could be covered by the RT or the pharmacist for medication education, while the self-management section could be the role of the RN or case manager, just from deduction. This is the last article, and I think we're pretty good on time, titled Pulmonary Rehab. That's what this article is titled. It's by Dr. Hill. He's the Chief Pulmonary and Critical Care head for Tufts University School of Medicine. This article was found in the American Thoracic Society as well. Now his was more inclusive of everything, the way I believe. He identifies pulmonary rehab program to use using multidisciplinary teams to optimize physical and social functioning of patients with chronic respiratory impairment. These programs provide rehabilitation in inpatient, outpatient, or home settings. It points out that at least 6 weeks is what the program should be, and usually consists of exercise, education, psychosocial, behavioral components. So his article touches on everything that, when we now think of a disease management program, he ties it more into pulmonary rehab, but when we think collectively, his article touches on a lot of good stuff. Alright, so the article describes the ideal pulmonary rehab program. The author speaks on the goals of the PR program to alleviate symptoms, restore functional capabilities as much as possible, and reduce handicap, thus enhancing overall quality of life. When you have a disease that you can't cure, the eventual goal is to make sure that you're living the best life you could possibly live in those conditions. He writes about the structure of the pulmonary rehab program to include the pulmonologist, respiratory therapist, physical therapist, occupational therapist, nutritionist, social worker, psychologist, and nurses in an inpatient setting. So just conclusion based on this. The setting discussed includes the outpatient setting, the inpatient, and the home settings. The essential components of a pulmonary rehab program in this article include exercise training, frequency, which is how often does the patient need to go to a pulmonary rehab program, how often do they need to go see their physician, how often in general, how intense should the program be, how specific should the program be for that patient, the educational part of what's needed to enlighten that patient on managing the disease, as well as the psychosocial and behavioral components of that patient's condition. When you're thinking of the behavioral component, are they still smoking? Do they still work in a mining facility? What are they doing that they should change in their behavior to improve their disease condition? The author believes in the efficacy of a multidisciplinary approach to COPD management via the pulmonary rehab program, citing roles for caregivers outlined. So that's pretty much a conclusion on this particular article. So here are the references. Like I said, we'll have the slides for y'all. It'll be on the Respiratory website, which is through the homepage at the end of the whole symposium. But just a quick summary. I know this is a cliche, but I've got to put it in there. There is no I in team, but the phrase stands the test of time. So at the end of the day, if we remember that, this is all about patient-centered care. It's all about the patient. The RT may be the one that may do the education today. It may be the nurse tomorrow. It may be the case manager. It may be the physician. It may be any member of the team. As long as we're all focused on patient-centered care, we should be okay for that patient's conditions to improve and manage the disease. Knowledge on who does what is important, however. Knowing where the buck stops, who's the last person that you need to call about a certain situation helps. And that's why we went over the team approach to COPD. Knowing how everyone works together, but also knowing how each individual plays a part to the patient's care. So that's my spiel on team approach. Any questions?
Are you